Okay, great. Good morning, everybody. Welcome to our Echo QI cardiovascular series. Good to see you all this morning, bright and early. By way of reminder, Cardio was founded in 2017, and its mission is to improve cardiovascular and diabetes health outcomes and eliminate disparities in Ohio's Medicaid population. This is an initiative of healthcare professionals across all Ohio's 7 medical schools, and we identify, produce, and disseminate evidence-based cardiovascular and diabetes best practices to primary care teams. And we do this through a variety of mechanisms, including on the online library of best practices resources, our web app, monthly newsletters, podcasts, webinars, and quality improvement using the ECHO model. Next slide. So this is our agenda. I'm going to do a welcome. I'm going to give a brief presentation, then I will turn it over to Gautam, who will do the clinical pearl and case studies. Then we'll hear from you all, and then turn it back over to Andy to wrap everything up. So I think everybody's aware of where our 6 sites are. Welcome to all of you. Thank you again for participating. We've got representation across the state. Here's our project team. I think you know who all of us are. Good to see you all again. Thank you to everybody on the project team and for participating. And I don't think anybody has any disclosures. So just a reminder that if you would like to receive CME, there's one category credit available for this, category 1 credit available for this clinic. You'll receive an email. Sorry. I think everybody knows this, so I will just stop saying it. But if you don't receive the email, contact Kathy Sullivan. Her email's on the slide below. So today we're going to define and differentiate process mapping and gemba walk methodologies, apply process mapping techniques to identify workflow inefficiencies in patient care, and you should be able to conduct a structured gemba walk to observe and improve care delivery processes. Next slide. Remember, please do not share any PHI. Okay, so now we're going to talk about process mapping. Next slide. So just by way of reminder, we do quality improvement to identify areas within systems that create waste, redundancies of effort, or suboptimal performance. And then we implement changes so that we can make improvements to those the systems that we're focused on. Next slide. We use a variety of tools to do this. First, we want to understand the process. So we use things like cause and effect diagrams, process flow charts, which we're going to talk about today, and Pareto charts. And then we implement and evaluate these changes using PDSA cycles, which I think you're all familiar with, run charts and control charts, which we're going to talk about at a later date. So has anybody ever used a flow diagram or flow chart or a process map? And if so, would you mind sharing your experience? Anyone?
Yeah, Aleece, we did on tracking basically some depression scores over time and seeing how many people we could do for essentially to get, we weren't doing them and then we weren't recording them correctly, and it actually helped.
And can you talk a little bit about why it helped, Austin?
So the biggest thing is like when we start talking about where the problem is, everybody just finger pointed to say like, oh, well, these are thoughts of why. And when we stopped and went through the entire process of where people were starting at the beginning, who was rooming them, who was responsible, who was charting them, who was reviewing them, it actually made a big difference. And then with that data, we just continued to roll with it into a run chart for a couple of weeks from the flow of seeing what the whole process was and then tracking it over time. So two, I guess, graphs or graphics made a huge difference in our whole office's understanding.
Great, thank you, Austin. That's a really good point. We're going to talk about that later, that Austin and his team used a team approach, and it's really important to use a team approach to gather everybody's perspectives when you're doing a flow chart or a process diagram, and I will use those terms interchangeably. So if you get confused, please put it in the chat or interrupt me and say, I'm not sure what you're talking about, because I tend to use those terms interchangeably. Next slide. Okay, can we skip to the next slide, Andy? Sorry. So here's an example of a flow chart. So I should cook more. So what do? I go out and I buy some ingredients. I put some in a pan. I cook them. Does it taste good? Kinda. Put the leftovers in the fridge. If it doesn't taste good, I still put the leftovers in the fridge. Um, and then some time passes and I'm still hungry. So I order a pizza because either what I ate didn't really do it for me, or I'm hungry again and I don't want to eat the leftovers. Um, Days pass. I throw out the leftovers. Then weeks pass and I threw out all those ingredients that I bought when I said I should cook more. And then months pass and I go back and I say, wow, I really should cook more and not spend all this money ordering food because it's really expensive. So this is an example of a flow chart. You can see that there's different shapes that represent different aspects of the flow chart, and I'll get into that in a minute. But the idea of a flow chart is it maps out a process or a workflow step by step. You use different shapes. The rectangles are for the tasks. The diamonds are for decision points. The ovals are for a start or an end point. And the focus is the sequence of actions and how things flow from start to finish. And it's really good for showing procedures, approvals, or organizational processes. So this is one example. Another example might be, how you measure blood pressure. In my case, I'm using it a lot for like the academic promotion process. There's lots of ways you can use flowcharts. Next slide. So as I mentioned, these are the different shapes. You can have the oval represents the start or the end. A rectangle represents a process step. Diamond represents a decision point. A small circle represents a connector. And then the arrow represents the direction for the flow of the process. So a lot of people get really bogged down in these symbols. I would suggest not getting bogged down in the symbols and just getting your flow chart on paper. So there's lots of schools of thought around this. If you want to make it look pretty, have at it. But really, what we want to make sure is that you understand how your current process actually works. Next slide. So when you think about questions that might help you guide your flowchart development, anything come to mind? Austin, when you did your flowchart, what questions did you have to help you develop, like guide your development?
So partially we went through the different things that the doctor and the staff did, and we found that was not really helpful. We needed to take it from the patient's point of view. So like the patient checked in, right? And then go through all the steps of where the patient is seeing people from their start to finish. So by going through that mechanism, we saw where we were failing essentially in that, like what we weren't doing by doing the patient's process.
Okay, so we're going to avoid the word failure and use opportunities for improvement.
That's right. That's right. We had a few, and we improved significantly. It was a wonderful idea because it's just like, oh, these aren't being done. And then we said, well, why not? And apparently the patient can do self-scoring in the waiting room or even beforehand and take questionnaires ahead of time, which we didn't know. That data can be implemented in the chart before or during the visit. The rooming staff can put it in as a direct manual entry questionnaire. The physician or whoever's seeing the patient can do the same thing. And then by the time you close the chart, you have to put it in. So there were like 5 different areas that we found as a result of the flow sheet or flow process diagram.
That's awesome, Austin. That actually raises a number of points for me that I was going to get to. But when Austin said a couple of things, when he talked about people, he talked about the patient, he talked about the staff, and he talked about the physicians. So it's really, really important to, if you could go to the next slide, Andy, to develop your flow diagram as a team, because everybody has a unique insight and perspective. So if you're thinking about blood pressure checks, who might be involved in that? Is it MAs and nurses, front desk staff, clinicians, and patients, right? So all of those people have different perspectives on how the process works, right? And then the other thing he said was the patient checks in. So I'm assuming that's where Austin was defining where the process actually begins, is at patient check-in, right? So if that's the process, and if that's a process starting point, the next question you're going to ask is, and then what, right? So is the patient called by the MA? Are they escorted to the exam room? Is that when I'm using the example of blood pressure, is that when blood pressure is taken? And then what would happen after that? Do they enter the blood pressure into the electronic medical record before the provider enters? There's all kinds of questions about, and then what? And then what? And then the next thing you might want to ask yourself or the team is, does anything have to happen before I do this next step? So if the patient checks in and you're having somebody check their blood pressure, have they been seated for a significant amount of time? Is the proper blood pressure cuff selected? Is the arm positioned correctly? And then you might ask the next question, and what do we do at this step? And are there any steps where a delay occurs? So sometimes the patient waits in the waiting room before being called. Maybe the staff is busy, which could cause delays. Maybe multiple blood pressure checks are needed, adding more and more time. And then the next question you would ask is, what do we do at this step? So example, why do we recheck the blood pressure if it's high? And then when you think about things, are you sure this is a process step or it could be a decision point? So if the blood pressure is greater than 140/90, is this a step? Do you record the blood pressure, or is it a decision point? Do you repeat the blood pressure or continue to the provider? So there's all kinds of things you can think about when you're flow charting these things. And, you can do a very high level flow chart. You can do a very, very detailed flow chart. And there's different ways to do this. Austin mentioned before about using different team members, and I'm not going to get into this, but we can do swim lane diagrams, which represents everybody's view of the process in one picture. And those are a lot more labor intensive to do, but provide some additional information as well. And we can, if anybody's interested in those, we can talk about those at a later date. Any questions?
No, the only thing I was going to add, Aleece, is when I have done flow charts, is just thinking about the beginning and then also the end as you start, because so many times as I've done these, we start out on a process map and then it goes on and on and on, and like no one has thought about, well, what's the end point for this particular project? So I just think that's important to think about as you're starting on the journey of creating those flow charts is, what are we actually working on, and where does it start and where does it end for this particular work or project?
Thank you so much, Amanda. I knew I was forgetting something, and that actually leads me to another point, is that you can have like mini process maps within your overall process. So maybe the MA is only involved in the beginning of the process, and then the provider or the nurse takes over, and then maybe the MA comes back in at the end. So you can have different sub processes within your flow chart. So, and it may help you to document and communicate where everybody's really involved in the process. If you identify, at this part of the process, it's just the MA and the patient. At this part of the process, it's the patient and the provider, and so on and so forth. So yes, define a beginning and an end of your process is really important. Next slide. So we just said that, define the beginning and end. There's nothing there's no such thing as a perfect flow chart. It's kind of a living, breathing document. As things change within your clinic, your flow chart might change. You want to keep it simple so that people can really understand it. And then, as I mentioned, you can have a 50,000-foot view or a much more 5-foot view, and then you want to add your details. And you want to flow chart your current process. You want to understand where the breakdowns happen in your current process before you think about making any changes, and not, and people will say, well, what if this happens? So like one time this happened. It's really, you want to use the 80-20 rule. What happens 80% of the time is a rule you want to go with when you're documenting your flow chart. And then you want to validate that this is how your process actually works, and not just how you think it should or hope that it would. So you want to talk to other people about it, involve people who may not have been participating in the development of the flow chart, but have similar roles within your clinic. Say, is this the best representation of how we document blood pressure? Next slide. So once again, once you have a final product, you can use the symbols. I don't tend to get caught up in the symbols. A lot of people do. They can be useful to some folks. Some people find that they're very visually helpful. And then you want to make sure all your process steps are identified clearly. Are all your loops closed? Does everything bring you to the end? And then once I said this before, was validate the flow chart with staff that carry out the processes, but we're not really part of designing the flow chart. Next slide. All right, so this is an example of how reordering a process can be really powerful. This is an example of a transurethral resection of the prostate. So before they changed the process, the patient would check in. Obviously, this is a very high level flow chart. They would have the procedure. They would learn to self-cath, and then they would be discharged. The length of stay was 5 days, and the cost was $20,000. Next slide. So somebody said, well, you know, patients go through this procedure. It's really painful. Maybe they're not up to learning to self-cath. What if we taught them how to self-cath before they checked in? So they reordered the sequence where the patient would learn to self-cath. They would check in, they'd have the procedure, and they would be discharged. Next slide. You can see that when they reordered the process, the length of stay should have changed to 1.2 days. I'm sorry, I did not update that slide, but the cost went down to $5,000. So you can see how, you know, really looking at your process and changing the sequence can have a powerful and impactful impact on your outcomes. All right, gemba walks. Gemba walks are super fun. So I haven't gotten to do one of these in a long time, but anyway, people are like, what do you mean by gemba walk? So it really comes from the term, the Japanese term, the real place. And it's the most important place for a team, and it's where all of the work happens. It's a concept developed by Taichi Ono, who is often considered the father of just-in-time production. It's really a good way for people to step away from their daily routine and see where the work happens and build relationships with their teams. So for example, for rock bands, the gemba is the recording studio. For Formula One teams, the gemba is wherever the car is. For manufacturers, it's the factory floor, and we can go on with lots and lots of examples. So really, the objective is not to draw a map or solve a problem. It's really to understand a situation by observing everybody and involving everybody who touches the process, understand the purpose and the people. And once the situation is understood, improvement is possible and much more likely to be successful. So when you're doing a gemba walk, you're going to observe. It's not meant to be a corrective exercise. You really want to understand what is working about the processes and really understand why they're doing the processes. And, you know, evaluate value. So where are you losing value in the existing process, and why are you losing it? And it really helps to innovate and improve conditions, tools and procedures, because it removes the elements that are detrimental to production. Next slide. So when you're doing a gemba walk, you want to focus on what you're working on, identifying whether or not there's already an established process. Like we talked about blood pressure quite a bit. Is there an established blood pressure checking process? Do you have any problems with the established process? If so, what is the problem and why is it there? And how can you fix it? And what do you do to recognize the root cause of the problem? And who do you speak to if there's a certain problem? So these are the things you want to think about before you get started on your gemba walk. So before we close up, before we end, I just want to say, I want to give you an example. So you know, if you're thinking about a gemba walk, you know, we talk, hang on. You want to observe, you know, so for blood pressure, it's like, you know, you want to observe the environment. Is the environment quiet and calm? Does the chair have back support? Are the patient's feet flat on the floor? Is the patient sitting comfortably? You want to observe the patient. Have they been sitting for a few minutes before the reading? Is the arm positioned correctly? Is the cuff the right size? Is the cuff applied directly to the bare arm? You might ask some questions of the team member doing the blood pressure check. Can you walk me through the process? What are your common challenges? How do you determine the correct cuff size for placement? You know, where is the blood pressure? So when you're thinking about the equipment, where's the blood pressure machine located? Is it easily accessible? How often is it calibrated? Who's responsible for that? And then patient interaction. How do you prepare the patient for the reading? What do you say to them? How do you talk to patients who, like me, who have white coat hypertension, to calm them down a little bit? Are there any variations or exceptions, and what do you do if a reading is unusually high or low? And then you're going to observe and document next steps. How is the reading documented? Is it entered into the electronic health record immediately? And how is it communicated to the provider or the patient or the rest of the staff? And then you're going to talk to the team. You want to thank them for letting them observe you, because this can be an uncomfortable process for team members. You want to summarize your findings and plan your next steps. So based on your observations, work with the team to brainstorm and prioritize 1 or 2 actionable improvements, and then maybe schedule a follow-up. I'm using this example because we had a previous project where we did some gemba walks. I think, Amanda, you actually participated in those, if I'm correct, for our Heart Healthy project. So that was just like an example of how you might actually execute a gemba walk, and how it differs significantly from a flow chart or a process map. Are there any questions? Comments? Can't see everybody in. All right, I think at this point,
Hey, Aleece, good morning. I'm sorry. I chimed in a little late. I just want to say we use something, the gemba walk, or a variation of that here at Fisher-Titus. So when we sometimes have difficulties between departments, we take key personnel and we take time out and go visit that office and see how things work. And they will subsequently will come to our office to see where maybe there's areas where we can improve the communication or the process and how we communicate with each other. So it does work pretty well.
Yeah, I found them to be pretty powerful tools. I mean, once the staff understands that they're not being evaluated and they're just being observed to really help them, they tend to open up and share with you, where some of the challenges are, but they also share with you what's going really well too. So you get the challenges and maybe you get some best practices as well. Right. I think I'm turning it over to Gotham now.
Right. Thank you, Aleece. Thanks, everybody. My first task is to describe the clinical pearl. And I thought long and hard about what could be a nice short clinical pearl that we could discuss. All of you are focused on cardiovascular risk prevention. For the vast majority of those people, weight loss is imperative. Hypertension is a condition, for example, that responds to modest weight loss. So let's say that we have a 61-year-old woman. She has both type 2 diabetes, of course, responsive to weight loss, and hypertension. She has a BMI of 40.13, also known as class 3 obesity. What I'd like to do is to talk about something that I've been promoting for about 15 years or so, and that is how to discuss weight with your patients, because it is a sensitive issue. There are 2 ways that people go wrong. One is to offend the patient by discussing weight in a disrespectful way. The other one is to minimize the issue, making it seem unimportant or trivial, saying, oh, by the way, lose weight, or don't worry about it so much, we'll talk about it next time. I was privileged to serve on the National Academy of Medicine's Obesity Committee 2017-ish, and the opening the door methodology was adopted into their recommendations, and you can download the entire book free of charge right now. It's what we call opening the door. And once you open the door, you can have a discussion of many other issues. So let me throw this question out to the folks. The 61-year-old woman, how might you begin a discussion if nobody has ever discussed her weight with her? What might you say to start the discussion?
Hi, Gotham. I think the first thing I would do is I would just make sure I attended to whatever their primary goal was for that visit. So if they were concerned about some issue, I would make sure I attended to that. That's the first thing I would do.
Okay. Now, how would you raise the issue of weight?
Once we're sure that we address the issue, if that issue has any relationship to weight, I would bring that up. I would say, one thing I noticed is that, your body mass index is high, and I think that this could be contributing to the things that we're discussing today. Would it be okay if we talk about that a little bit?
Good. That's pretty close to what we recommend. Anybody else have anything to add to that? Okay, let me tell you and give you a very, very prescriptive way to begin the discussion. And this is all laid. Next slide, please, Andy. So the first step, and it is prescriptive because it works. I've used it thousands of times as of residents that I've trained and others I've worked with. So the first thing, and I think Mike was on the right track, you have to express concern. And you can do that by just saying, I am concerned about your weight. Stop. Period. Then you medicalize the issue, which Mike was getting at as well. It puts you at risk for heart disease and for making your diabetes and hypertension worse. Never, ever, ever discuss the cosmetic benefits of losing weight. Never say anything like you would look and feel better. You'd feel better about yourself. That is none of our business as far as I'm concerned. Some of these people may feel perfectly well about themselves. Unless they bring it up, you do not do that. Then you don't let them take a breath, basically, after you mention it's putting your hypertension, your diabetes, making those worse, for example. Ask the question, which Mike was implying, permission issue. Is this something that concerns you as well? And the final part is this something you and I could work on together? So what are the three elements of raising the issue? First of all, an expression of genuine concern, no sugarcoating, which we often hear. Yeah, your weight's a little high. I'm sure it's summertime. You'll start to lose more weight. Don't worry about it. Not a good thing to do, because the message they hear is that they don't have to worry about it. It medicalizes the issue. Like I said, never mention any cosmetic or social benefits. That can be highly, highly offensive to patients, and not just women or young people or old people or men. It's everybody. Never, ever do it. And the third, and perhaps the most important part of this approach, is when you ask, is this something you and I could work on together? You're not telling the patient, you go out there, lose weight, find a way to do it, because that will make it easier for me to control your blood pressure or for me to control your type 2 diabetes. That's not how it works. Why is this called opening the door? Because in attempting it personally thousands of times, others tens of thousands of times, I have yet to hear of a single patient telling a physician, no, I don't want to work on this together. I'm not concerned about it at all, right? Now, that doesn't necessarily mean that they don't have ambivalence when you mention this. They can say, yeah, I guess I kind of want to work on it, but I just told him I really wanted to, or I guess I could work on it with him, but my sister-in-law is really the person who helps me with these things. That might be true, but still you have opened the door. Once you have opened the door, you can talk about diets, you can talk about exercise, you can talk about weight loss medications, you can talk about diabetes and how it can be aggravated by your weight. But if you do not open the door, you are liable to mess up. And once you do things the wrong way, and I know that a lot of you have followed my echo sessions for years, but the University of Chicago pediatric echo, the worst example I ever gave, because it's pediatric obesity, was a resident who told a 16-year-old boy that he would be more likely to get a date for the prom if he lost weight. And the look on this kid's face was like, I will never forget it. He just froze. He never came back to that clinic again. Now, she was a young resident. She thought she was doing a good thing, but she had closed the door essentially on any further discussions. That kid is going to associate going to a healthcare professional with being deeply, deeply humiliated, which you do not want it. And that's an extreme example, but we often use language that you don't want. You'd feel more energetic. You'd look great. That's not our concern, okay? Especially in something that relates to cardiovascular risk. Any questions about that, Pearl, before we move on? Okay, Andy, I think we can move on to the next issue. So this is our case discussion. Case discussions are loosely related to your projects and some of the things that Aleece talked about. So we talked about flowcharts today, for example. So let's start the case, and we will go, I think, Andy, keep me on time, please, which you're very good at doing. Excelsior Primary Care serves a primarily Medicaid population in Cincinnati and wishes to develop a process map for a project to improve identification of patients who can benefit from statin therapy. And I know some of your projects deal with this. So the questions for discussion would be, what would be the starting point in your process? Let's start with that one. Anyone have any questions? Any thoughts about it?
This is Arpita. So the starting point in the process can be finding the data for patients who are on Medicaid and seeing like the demographics and just going backwards to see why they are not on statins to start with the process.
Okay, so and let me ask you, so you would go to your IT department or something of that sort, assuming that even this primary care office you'd probably need some sort of computerized
Data, yeah, information
data.
like
So looking
or
at
like
Medicaid
expertise.
recipients, and how would you find out? And you would exclude people who are already on a statin, obviously. And how would you find out who would need a statin?
Depending on like at Metro, we use slicer dicer to see like ASCVD risk scores, patients with
Okay.
CKD, diabetes, and like who are qualified for statins but not on statins.
Okay, so I think there's many different ways. I want to get into the nuances of different risk scores, and we talked about a new risk score coming up soon, but you could look at just LDL cholesterols, et cetera. And if they had one in the last year, and you may even be very liberal and say they haven't had a statin in the last year, but they have some other cardiovascular risks, and therefore they could benefit from statin therapy. We don't know. Okay, let's say you have that information now. What 3 steps would you take next? Now, we're talking about identifying patients. I'm not talking about putting them on a medication, monitoring liver enzymes, none of that stuff. But just after you identify potentially eligible patients, what would you do next? Anyone?
Having a data map, like how Dr. Karen was mentioning about flowchart and like process mapping.
Good, excellent. So that would be one. Any additional steps?
Dr. Rao, it's Jim from East Liverpool City Hospital. So what my thought is that ask the patient about their opinion about statin therapy after discussing the risk and benefits of statin therapy.
Okay. So that's an important step. So we've identified people, and say we have to do additional, we have to do additional laboratory testing because some of these lipid panels may be quite old, and you want to repeat them. But you can ask the patient. So if you have Epic, for example, or some other electronic, you could shoot out a message to them. Probably not that effective. You might have to make some phone calls as well. Okay, and any additional step beyond that? Let's say you've asked them, you've identified who it is. What would you do next? Any thoughts?
Send the medication once they agree to it.
I'm sorry, say that again.
Send the medication once they agree to it.
Yeah. So yeah, you would probably have them come in and have a discussion about medication, and if they declined or if they had some sort of contraindication, you could document it as well. Now, in reality, this process would be a bit more detailed with additional steps in the flow diagram. Final question before we wrap up this part. We have a couple minutes left, but what challenges might the practice face in implementing the process. Just the process of identifying, discussing, having sort of a shared decision-making discussion with them. What would be some of the challenges you might face?
The challenge that we usually encounter is their level of literacy in terms of statin therapy, because some of them do not have any idea what the medication is for. And on the flip side, some of them do a lot of research in Google University, quote unquote, by saying, hey, my research told me that it can cause this and that, so I'm not taking that one, because they take information from Google hook, line, and sinker without even understanding the full benefits of what they're reading.
Yeah, so health literacy is a huge problem. Even if you get to the point where you have a nice discussion with them and you prescribe the statin, chances are, if they have low health literacy, their engagement with taking the medication would be lower than optimal, right? That's fairly common for sure. Anything else further upstream in the process in terms of identifying patients, etc.?
Loss of patient population,
Yeah.
having patients like either dead or like transfer of care or like any other reasons, but still like listed as, and they might be actually on a statin, but might not be showing in our records too.
That's right. So lots of data problems, as Arpita said, for example, are they really still on Medicaid? I mean, a lot of people in the coming years may be kicked out of Medicaid and will have to reconsider their eligibility. They may move from the area. Phones are disconnected. They don't use MyChart. They don't use email. So contacting these people would be hugely challenging as well. So a lot of those things are true. So you may wind up with some patients that a smaller subset of patients who are engaged in healthcare, who have regular insurance, who've been coming in regularly. Those patients probably have already, perhaps a lot of them have been considered for a statin, so you'd have to wonder about it as well. Okay. And how might you engage the physicians in a project of this type? Just some thoughts there before we wrap up.
Population health.
Okay. What would you do? What would you tell, let's say you only have 4 colleagues and you're leading this project?
I would start with getting their data with their permission to see these are the statistics, and this is how much we can make a change for your patient population, and encouraging them to start there.
Yeah. And always frame it in a positive way. These are some of your patients potentially eligible for statin. What do you think? Am I off base? And sometimes you get some really great information. Oh, that lady always says no, and I just never documented it. Or I don't think she should be on a statin because she has active liver disease. Who knows what it is in particular? But they can be very helpful. And most of the time, most providers are very open to these sorts of QI efforts. Okay. All right, I believe we are out of time, so I'm going to turn things back to, I guess, Andy, we can go through project updates. And Aleece, perhaps?
Actually, I think it's Amanda.
It's Amanda. I'm sorry. Go ahead, Amanda.
No, I think at this point, we would just love to hear from you all and get an update on what you're working on, your current PDSA ramp cycles, and then how did that go? Any challenges that you're facing that maybe we could learn from one another. And then thinking about next month, trying a gemba walk in your practice, and then reporting out in the October call on how that went, what you learned, because I'm sure when you do the gemba walk, you're going to get a lot of insight and learn a lot of things that maybe you hadn't thought of. So we'd just love to hear from you next month about that. So we have East Liverpool up first. Do you want to start and just talk us through what you're working on, your current PDSA cycles, how that's going?
So good morning, Amanda. So we just had a meeting, I think a week or 2 ago, regarding updates on this one in terms of our data. So far, we are um, gathering the data just like how we are supposed to, and working on um, patient follow-up to make sure that the rest of the residents set that follow-up towards the end of their visit. So yeah, and then making sure that we send the medications to our patients, the statin medications to our patients.
So you're currently working on making sure patients are getting scheduled for follow-up and then coming in for their visits.
Yes, that is correct.
Okay. Have you had any barriers to that or identified any challenges?
Yes, we have identified some barriers wherein some patients just walk off the clinic without even stopping by to check out at the front desk, and it is a challenge considering sometimes it gets too overwhelming at the front desk. So it's a work in progress.
Okay, I think that's something that we can continue to work on. Yeah, just making sure that we're capturing them before they leave the clinic, because that's so important to get them scheduled um, before they leave. So thank you for sharing.
Yeah, sure. Thank you.
Erie County, do you want to talk to us about what you're currently working on and how things are going?
Hi, can you hear me okay? Sometimes I have issues with my microphone.
Yeah, we can hear you.
Okay, perfect. So one of the PDSAs that we're working on currently is flagging patients with A1Cs out of range. And that helps to alert all of our team members each morning that we have a patient that has an A1C that's out of range or isn't exactly where we want it to be. One of the things that we're doing with this project is connecting patients to food resource kits. So we partnered with OGO in our community, and we have about 200 food kits within our provider office rooms as well as the patient rooms that are accessible to anyone that screens, not only for food insecurity on the Prepare assessment tool, but patients that have an A1C that's out of range. That's one of the things that we're trying to provide to them. In addition to that, I know I had a one-on-one call last week. And one of the things that we are going to be implementing is putting in information regarding healthy eating habits into the food kits, and then getting feedback from our patients, making sure it's easily readable, that it's colorful, that it provides good information to help facilitate and promote overall wellness and healthy eating habits.
That's awesome. Thank you for sharing. I love that you're flagging patients with the highway A1C to alert all the team members, so everyone can be aware of implementing the processes that you guys are doing. And then the educational information, including the patient on that and getting feedback from the patients. I think that helps with just making sure that they have an understand the educational materials, and then helping them also to buy into the changes in the process. So thank you for sharing. Fisher Titus, David.
Good morning. Yeah, so we actually have a couple things going on at the moment. So our hypertension, our gathering of data is going well. The clinical staff engagement with the providers has been getting much better. They're identifying especially new patients who are coming in for potential hypertension. And when they do have somebody who comes in that is new, they do identify that patient to me, and then we track, make sure that patient comes back in. So we are doing pretty well with that. The providers are also on board for that. Unfortunately, it seems like our 60 and above population is not as keen on following or coming back in to be seen. Our younger folks are doing a little bit better with that. We are rural, so that does tend to happen with our folks. On the flip side, I went back and did some of the A1C sampling for the patients from May and June. and we're following them. So we do have a really good follow-up with patients, especially those that are coming from distance, to have the A1Cs done in the office at the appointment time. So that's working well. What's not working well is getting the patients to accept or agree to come in to see dietary or accept some of that information to help them out. So we're trying to develop that a little bit more. So more to come with that.
Just curious if anyone on the call has any suggestions for David on how to engage that population of 60 and above, getting them to come back in and be seen.
What I will tell you is I'm embedded in my offices, and I do, when we have those patients, I do sit down and talk to them and tell them what we have available to help them out as far as coming back in and being seen, to make sure that the medication dosage is correct and that it's effective. But unfortunately, that one-on-one talk doesn't seem to help for some. It does probably for about 10% of that population, but the other, 90%, which are generally men, are pretty fixed in their beliefs.
Sure. Okay. Well, thank you for sharing. Healthcare Connection. I don't know that I saw Nate on this morning.
Amber was on earlier, but I think she's hopped off.
Anyone on from Healthcare Connection? Okay. Metro Health?
Can you hear me okay?
Yes, we can hear you.
Thank you. So our project is actually going slow this month. We had a provider who part of the project is out of office, but for a few months. So it's getting the engagement from the physicians and the nursing is slightly slower. But the good thing is we identified a lot of patients who are actually who are not our patient population. So we excluded them, and we are also trying to have the patients mark as like the comment if they are statin intolerant or like just a quick update. Our project is having increase in the rates of patients with ASCVD risk score over 10 to start on statin who are not actually on statin. So it's as we discussed today, it's hard for the patients. Health literacy, accepting a statin is a hardest thing that I realized out of all the medications. And that's like, I'm trying to have follow-ups with patients who are not on statins, but they are willing to start if it's not improved. So having those things are in place, but overall it's going very slow this month.
Well, thank you for sharing. And it sounds like that you're doing a good job of pulling that data and identifying the patients that could benefit from this work. So
thank you.
Continue to move forward. Let's see. Next, we have Village of Healing.
I don't think anyone's on for Village of Healing today, Amanda. So I think we can move on. We'll wrap up a little bit early today. Just a reminder that you should have received a post-clinic survey in your inbox about 5 minutes ago. We're giving you a little extra time from now on just because they are month-to-month clinics. And so please complete this by next Friday, the 12th by 5 p.m. And then a reminder to submit your de-identified monthly practice data via RegCap due the 8th, so in just a few days, 20 patients that you saw in August. And just a reminder that while you submit the de-identified form, please hold on to the identified lists for future cross-sectional analysis. Otherwise, our next clinic will be October 2nd over additional QI tools.
Thank you, everyone.
Thank you, everyone. Have a great day.